This time I'm going to talk about chondrocalcinosis, and as the name implies, chondro, the cartilage, and calcinosis is calcification. And it's the other synonym is calcium pyrophosphate deposition disease. So, and we started just to call it CPPD. It's arthritis caused by this sort of crystals, and until recently, CPPD disease has been referred to as pseudo-gout. And pseudo is, it's not the real thing, so it means that it is similar to gout. And the term acute CPP crystal refers to acute inflammatory arthritis, which was formerly called pseudo-gout. And the term chronic CPPD is used to other types of arthritis associated with these crystals. So the acute type of arthritis, or what used to be called pseudo-gout, is the most widely recognized form. And usually it is acute monoarticular, more than even oligoarticular. There is warm joint, erythema, swelling in and around the affected joint. Commonly it's the knee, and followed by the wrist. And very rarely it affects the first metatarsophalangeal joint of the foot. So never miss the chance of thinking about it when you see a hot knee with erythema and swollen, and never miss the chance of aspirating this knee. There are sometimes systemic symptoms. Might be low-grade fever, chills, some other constitutional symptoms, and the acute CPPD usually lasts, unless you treat it, for many weeks and even months, in contrast to acute gout. And I remember that my first, encounter of studying about gout is that it's the most painful condition. However, whether you treat it or not, it will fade within say 10 days or 2 weeks. Yet in this in pseudo-gout, it might last for months unless you treat it. So the chronic type, however, there are several clinical phenotypes. Most patients are polyarticular, resembling very much osteoarthritis. And the osteoarthritis sort of presentation is distinguishable from the typical osteoarthritis, that there are flares of inflammatory signs and symptoms, and by the severe articular damage. And that's the other thing, is that by the time the patient reaches you, the joint is so much damaged that even you cannot see the calcified, the chondrocalcification. Glenohumeral joint, which is normally not affected by osteoarthritis. Wrist is not affected. I teach my students, I say, somebody with painful hand, just to try to flex and extend the wrist and squeeze the wrist. And if the wrist is tender, there is the possibility this is rheumatoid. And if the wrist is not affected, the more likely that you are dealing with osteoarthritis. So the metacarpophalangeal joints might get affected by CPPD. And these are not typically associated with osteoarthritis. Rheumatoid-like form, and this is again a rarer form of polyarticular CPPD, and the patients have persistently inflammatory arthritis affecting large and small joints, and flares occur sequentially and is usually less symmetrical than you can see in rheumatoid. Rheumatoid almost always respects symmetry. So what you see in the right hand, you see it in the left. There is one also subtype that we have been now noticing, especially with the presence of CT scans and MRIs. Then we can see that it's the crown dense syndrome, and this is sort of around the joint between the C1, C2 intravertebral disc. And the crown dense syndrome is caused by the deposition of CPP around the C2 vertebral C2, particularly around the dense process, and manifests as acute severe neck pain, fever, and high inflammatory markers, and even meningism can present in these patients wrongly diagnosed as meningitis. Pseudoneuropathic and the CPP crystals here are associated with severe destructive arthritis, very similar to Charcot joint. But here, the sensation is normal, and the neurological examination is normal to differentiate it from Charcot. This is sort of a map of the pathogenesis and the formation of the CPP crystals. I'm not going to go through it. It gives me a headache to look at it. So, chondrocalcinosis probably identifies only 40% of the patients that are clinically with the clinically significant disease, and it's particularly difficult to visualize on radiography in patients with the severe cartilage loss. I'm sorry that with the difference of the office sort of program, the photos seem to have overlapped a bit on the text. I apologize for this. So CPPD disease appears to affect 4% of adult population in Europe and in the USA. Probably it's more in the developed countries. It's the disease of aging, and it's rare in patients under 60. We will come back later that people who are younger than 60, you must think of metabolic diseases that are causing it. In X-ray examination that include knee, pelvis, and wrist, chondrocalcinosis is detected in nearly half of the patients, 44% of those who are above 84 years old. There is previous trauma is a strong risk factor for the development of CPPD, and this shown in meniscus. And what they did is, in one study, that decades after meniscectomy, chondrocalcinosis developed in 20% of the knees that was treated by meniscectomy versus 4% of the contralateral knee. So the trauma of surgery itself was enough to cause it. Metabolic conditions, high ratio of inorganic phosphate to phosphate ions in patients with hypophosphatasia. And yesterday, my colleague and friend John mentioned about phosphate. Was it you talked about hypophosphatasia, John? He presented one of the cases of CPPD and with a very low alkaline phosphatase in these patients. Congenital syndrome is caused by non-functional alkaline phosphatase. Hyperparathyroidism alters the calcium metabolism, and also the CPPD can actually, persist even after correction of hypercalcemia. which suggesting some sort of complex relationship between hyperparathyroidism and this condition. Hemochromatosis, again, is one of the causes because probably the iron itself causes inhibitory action on the phosphatases. Magnesium also helps in increasing the solubility of the CPP, so people with hypomagnesemia will develop this condition. Gout itself, 5% of patients with gout have also CPP crystals in their synovial fluid, and this supports some hypotheses that these diseases share common local and systemic factors. So, actually, patients younger than 60 who present with CPP disease, we should test for all the conditions that I mentioned. And the other risk factors is osteoporosis and low BMI and the genovirus disease. So what studies you will do for these patients? Probably I would still send them, that I'm talking about young people. Older people probably, it's just waste of resources. But younger people, you should do serum calcium, alkaline phosphatase, parathyroid hormone, iron studies such as iron transferrin, ferritin levels for detecting whether there is some sort of metabolic condition. There was no dietary association that was found in this disease, but several medications, loop diuretics, a granulocyte macrophage colony factor that they use for monoproxetine has been found to be related. Pamidronate, interestingly, which is used as an anti-absorptive drug, also have been associated. And I tell you one thing is that I'm a rheumatologist, and up to now, I almost never inject hyaluronic acid in knees or in joints. And the reason is that even the latest 219 ACR criteria or guidelines for osteoarthritis doesn't encourage hyaluronic acid. There is low molecular weight, high molecular weight, and there is no real sort of studies that prove beyond doubts that hyaluronic acid does any benefit in osteoarthritis. So I don't inject it. It was found that injecting preparations of hyaluronic acid induce acute CPP crystals. Patients with non-familial chondrocalcinosis had lower cortical bone mineral density and higher rates of vascular and soft tissue calcification. So it's just not just the chondrocalcinosis, but calcinosis even in the vessels and in the soft tissues. So familial type of chondrocalcinosis occurs in patients younger than 60 years of age, and we should always ask other family members. And I came across full families with all the siblings having the condition. And this was found to have genetic loci that are associated. It is underdiagnosed condition. 20% of unselected patients that were examined at the time of total knee replacement for osteoarthritis of the knee have CPP crystals in their synovial fluid. So, and these were not diagnosed with the condition before the surgery. The most accurate way of diagnosing the condition is finding the crystals which are positively birefringent rhomboid-shaped crystals in the synovial fluid from the affected joint. I came across one study that mentioned that despite that this microscope is available in most departments in USA, it very rarely they use it. So it's interesting that it's not, although it's available, rheumatologists, for one reason or another, they don't try the polarized light microscopy for crystals. Conventional radiography may assist in the distinguishing the CDBD from other types of arthritis. And although the condition is, as radiography finding that most closely aligned with CDB disease, it should not be used as the sole diagnostic criterion. So we have to have some synovial fluid analysis, and even better, having polarized light microscopy done on the fluid. There are typical radiologic clues for CPP. It's a long list, but this is sort of hook-like. So hook-like osteophytes, also sort of bigger, sort of beak-like. Here, vacuum phenomenon. I must say they are not really specific for the condition, but once you see it, they might support this diagnosis. Here also, vacuum phenomenon. Ultrasound is useful because you can see linear densities in the hyaline cartilage or fiber cartilage. However, they look very similar to gout also, and you might also need to distinguish them from uric acid. Computed tomographic accurately detects calcifications and is particularly useful in detecting the CPD. And the MRI actually is a bit insensitive to tissue calcification. In treatment, most of the treatments are borrowed from therapies of acute gout. So aspiration is the first line therapy, and aspiration itself is a therapy for these patients. As much fluid as you can. Many times it is blood, sort of stained fluid. Oral colchicine, which is my favorite, it is cheap and available, and 0.6 to 1.2 milligrams is taken daily in patients without clinically significant renal or hepatic impairment. The evidence supports efficacy of daily colchicine when you give them prophylactically. NSAIDs are also have got role. Again, it's very similar to gout. So given anti-inflammatory daily dosages can be used, but preferably, most patients, I give them gas for protection if I think we are going to use NSAIDs for longer than 10 days. Systemic glucocorticoids, frequently used in elderly persons who are susceptible for CPD, and most experts agree that these agents are moderately effective in reducing pain, inflammation in patients with acute CPD crystal arthritis. Interleukin-1 beta, in case reports, support effectiveness of the interleukin-1 beta inhibitors. Again, very similar to gout. Gout has also, have been interleukin-1 beta as part of the armamentarium for gout. So this is sort of more or less tells what I was just describing. So I'll just skip it. Chronic CPD is much more difficult to manage than acute CPD. gout in the sense that in gout we have allopurinol probably and febuxostat to give to patients to prevent the attacks. However, in CDP, we don't have disease-modulating treatment as it is available for gout. Magnesium has been sort of recommended for patients to supplement magnesium deficiency. Methotrexate has been also, been mentioned in many sort of resources. Potential future treatments, anticrystal therapy, such as probenecid, phosphocitrate, and polyphosphate for future. And joint replacement is the ultimate, whether it's CDP or other, severe osteoarthritis. So my last slide, and this guy is saying it's sad thing about this job is in 70 years we will still be bald, no teeth, and wearing diapers.